Hi, everybody. I'm Brenda Viola for LymphaPress, and I'm so delighted to welcome you to our educational webinar series. This has become an annual event every June, which is Lipedema Awareness Month. We are honored to have Dr. Karen Herbst present for us. And if I could hear the audience right now, I would probably hear collective clapping. We have such a trajectory of amazing content. A few years back, we did Cooling the Fire Within. We also did The Mind, the Body, and the Matrix, the pathophysiology of lipedema. And today, Dr. Herbst is going to be speaking to us from content first presented at the Fat Disorders Resource Society conference back in April. And yet it's different. And I knew it would be different. You've been still adding things up until showtime, haven't you, Dr. Herbst?
Up until a few minutes ago.
I love that. So it's breaking news. We want to welcome every one of you who are logging on. I want to let you know that, yes, this is being recorded. It will live on the LymphaPress website as well as our YouTube channel, LymphaPress USA. Please do let us know who you are in the chat, and you can put your questions in the Q&A at the end of the presentation. We will certainly get to as many questions as we possibly can. I want to, even though she needs no introduction, I need to say Dr. Karen Herbst is a star when it comes to the field of lipedema. She is a shining light for both researchers and patients alike. She is known for her work in Derkham's and lipedema, her research regarding adipose tissue. Patients know her as someone who truly cares, and researchers know her and clinicians know her as a brilliant mind. She is also one of the anchor panelists for what has been known as our research roundtable here at LymphaPress. It's just an honor always to work with you, Dr. Herbst. And without further ado, I am going to hand the floor over to you for your presentation.
Thank you so much. And I want to echo that we do have a research roundtable monthly. It is primarily for providers. And if you are not already on our list to attend those, you should contact Brenda, because we have the most amazing guests. It's a very casual atmosphere, and I learned so much. It's just, especially, we had Dr. Cinti on this month, right? And it was just incredible. So
Yeah, good stuff.
I just wanted to tell everybody that I am now at the Roxbury Institute. I am the head of research and director of diagnostic and preventative medicine at the Roxbury Institute. I am in Tucson, Arizona, and the parent company is in Beverly Hills. And I'm going to talk about things you may not have known about lipedema. And my disclosure is I am the medical director for LymphaPress. So I'm primarily going to review the literature today, but I did do a chart review in my last practice on 100 women with lipedema, and I will present some of that data. I also measure body fat, body muscle, and body fluid using bioimpedance spectroscopy on my patients, and I will present just a tiny bit of that data. So this is kind of a busy slide, but we do consider that lipedema is an inflammatory condition. There's inflammation within lipedema tissue. And the question I have is, well, why are metabolic parameters usually in the normal range? So I want to just unpack this a little bit. When I first started studying lipedema, I was reading Dr. Foldy and Foldy's textbook of lymphology, and they showed a lot of macrophages in lipedema tissue. And many other groups have also shown that there are more macrophages in lipedema tissue than in matched controls. And what's really interesting is one group showed that there were more M2 macrophages, and M2 macrophages are anti-inflammatory. So that gives us a clue that inflammation in lipedema is a little bit different. Lipedema tissue also secretes lots of adipokines and cytokines, and some of them are shown here, but I want to point out VEGF. So if we could remember that that is increased from lipedema tissue, as well as PPAR gamma. There's also neurogenic inflammation in the nerves in the skin of women who have lipedema, and there are leaky vessels, and we think this is secondary to inflammation. So these are the 4 things you want to hold in your mind. Here's all the references for those papers. I could not fit them all on that first slide, and I'm sure if you need any of these references, they'll be on the recording. So there are different kinds of inflammation, and according to Phil Scherer's group out of UT Southwestern, this inflammation can be immunologically fit or immunologically unfit. And examples of immunologically fit inflammation include short-term or intermittent fasting, where you have an increase in M2 macrophages in adipose tissue, but also in the liver. And that sounds a little bit like lipedema. The sympathetic nervous system is activated, so you get lipolysis of fat, so loss of fat, which is something we really don't see in lipedema. But VEGF is elevated and vascular permeability is decreased. So some similarities and some differences with lipedema. Weight loss and wound healing are other examples of immunologically fit tissue. Examples of immunologically unfit tissue include metabolic obesity, fasting in the presence of metabolic obesity, high-fat diets, and critically ill patients. So I think the take-home message from this slide, in addition to immunologically fit being difficult to say, is that inflammation can be beneficial for the body. So here's the hypothesis for how lipedema begins. So in patients with lipedema compared to matched controls, lipedema gluteofemoral white adipose tissue, see that lovely abbreviation, was characterized by a chronic low-grade inflammation with substantially increased levels of oxidative stress. So low-grade inflammation in gluteofemoral white adipose tissue may be a primary pathophysiological factor triggering the development of lipedema. So let's unpack that. So we've known for a long time, or we've hypothesized for a long time, that lipedema is evolutionarily important tissue. In times of famine, you want to hold on to your fat tissue if you're a woman, so you can reproduce and also feed your young. So a hypothesis is that a subset of pregnant women develop increased intestinal permeability known as leaky gut. This leaky gut allows lipopolysaccharide, which comes from bacteria, to enter into the body, causing inflammation, which we describe as endotoxemia. And it may be that there's a whole spectrum of leaky gut. There's some guts that are very leaky and some that aren't very leaky, and everything in between. And I tried to find in the literature how many women, pregnant women, truly have leaky gut, and there's not a lot of data. If anybody in the audience knows, that would be fabulous. So why does this happen? Why does leaky gut happen in pregnant women? Well, intestinal permeability is increased by the increased estrogen production that occurs throughout the pregnancy. And estrogen levels reach their maximum value in the 3rd trimester. So that should be when the gut is the leakiest. And what does estrogen do? It reduces the integrity of intestinal tight junctions. So just by being a woman compared to a man, we should have the higher risk of having a leaky gut than men. Well, not all women with lipedema are pregnant all the time, and not all women with lipedema develop lipedema when they're pregnant. In fact, most women develop lipedema around the time of puberty. So how can we translate this to non-pregnant women with lipedema? Well, interestingly, aromatase, the aromatase enzyme, abbreviated CYP19A1, converts androgens to estrogen. And aromatase is elevated in lipedema thigh adipose tissue, in the stromal vascular fraction from lipedema liposuction, and cultured adipose stem cells. And this comes out of a beautiful paper just published by Sarah Al-Gadban last month, actually, or even maybe this month. So let's look at what happens when your estrogen levels increase. So on the right, you can see a columnar graph. You've got controls, And in controls, you've got plenty of zonulin 1 mRNA. And zonulin 1 is involved in the tight junctions in the gut, but also in other tight junctions between cells. And you can see as we go over to the right, as estrogen increases, the amount of zonulin 1 mRNA decreases. So tight junctions lose one of their components as estrogen increases. So let's go to Dr. Kruglikov and Dr. Scher's cartoon diagram of what's going on. So in advanced stages of pregnancy, you have high estrogen levels. In lipedema, you have high estrogen levels. This causes leaky gut, and that little green squiggly is lipopolysaccharide. It comes into the body and it interacts with all tissues, including gluteofemoral white adipose tissue. In this white adipose tissue, the LPS interacts with a receptor called toll-like receptor 4. And toll-like receptor 4 recognizes pathogens in the body. So it's recognizing LPS as a pathogen. And when it interacts with it, it sends out a cytokines signal, which results in the endotoxemia. So here you have your lipedema fat interacting with lipopolysaccharide through the toll-like receptor 4. And in addition to secreting cytokines when this interaction occurs, the alternative complement pathway is activated. It starts with complement 3, then complement factor B and complement factor D get activated, and then complement factor 3 through 9 come together to form a complex called MAC or MAC. And MAC intercalates into the membrane, causing a pore to form. Well, if a pore forms, the cell is going to die. And that's not what's happening in lipedema, because lipedema fat hangs around. So there's the MAC complex, C3 through C9. That's the little blue structure, and there's the pore. So what they think the fat tissue in pregnancy and lipedema does is it starts to set off a whole cascade to prevent that pore from forming. So first of all, it downregulates complement factor D. Then it expresses the most potent inhibitor of the MAC complex, CD59. It also increases matrix metalloproteinase 14. That's an inflammatory enzyme, and it cleaves the MAC complex, shedding C3b. In addition, the adipocyte grabs the MAC complex through a caveolin-1 dependent endocytosis reaction and pulls it out of the membrane and into the cell. So many different pathways are modulating the inflammation that has developed due to this leaky gut and lipopolysaccharide. In addition, there's an inflammatory pathway that gets activated by pathogens, including lipopolysaccharide, and this is called the NLRP3 inflammasome. And it's a complex of NLRP3 and apoptosis protein and also caspase 3. And those three proteins come together and form a pore and cause apoptosis of the cell. So this is another mechanism to kill off these pathogens or kill off fat cells. And that's called pyroptosis. So let's look at that a little more closely. So there's your NLRP3 inflammasome. There's your caspase 1, which causes pores to form and causes the pyroptosis. And then the inflammasome also causes a secretion of many cytokines. And that would generate a lot more inflammation. But what the pregnant adipose tissue or the lipedema adipose tissue does is it upregulates PPAR gamma. And we saw that in our initial inflammatory slide. And PPAR gamma inhibits caspase 1 and inhibits the release of cytokines. So you don't get pyroptosis, you don't get a cytokine storm, you just get a subclinical level of inflammation and your lipedema tissue hangs around. But we know that lipedema tissue is very fibrotic. So what about that? So in another paper by Dr. Scher's group in Obesity Reviews is that lipopolysaccharide induces the production of endotrophin. And endotrophin is also known as collagen 6 alpha 3. And together with that matrix metalloproteinase 14, that generates a condition that would increase local fibrosis. So now through lipopolysaccharide and leaky gut, we've developed fat tissue that hangs around and becomes fibrotic. And that really describes lipedema tissue nicely. So here we have our 3 stages of lipedema from our standard of care paper. And the question I always have when I look at papers that present the different stages is, how can these all be lipedema? What makes women with stage 3 develop stage 3 compared to women who have stage 1? And I'm not sure we have the answer to that, but I'm going to make a proposition today and would love to hear what you have to say about that. So we know that saturated fatty acids can stimulate TLR4 signaling in many different cells: monocytes, macrophages, adipocytes, skeletal muscle cells, pancreatic beta cells, liver cells. So this is a prominent mechanism throughout the body. And lipopolysaccharide is actually made in part of saturated fatty acids, which is why it stimulates that TLR4 receptor. So if we eat saturated fatty acids like pizza or other foods, I'm sure we have nutritionists in the audience who can give me a full list, then they can signal every time we eat saturated fatty acids, they can signal through TLR4 to generate this inflammatory complex, which then the body is going to regulate down to a small roar of inflammation. And I think this is one way that lipedema can spread. So if you are a woman with lipedema, you have your lipedema tissue and you happen to eat saturated fatty acids that activate this pathway, you can actually build a little bit more lipedema tissue. And then when you lose the non-lipedema tissue, you notice that, oh, I have a little more lipedema tissue left behind. And so again, I think this may be a mechanism how lipedema tissue can grow over time. I don't think it's just lifestyle that affects the growth of lipedema tissue. I think it also can be through genetics. And so genetics can cause an increase in adipose tissue, which would then influence the development of lipedema tissue. So I ask my patients, what was your highest weight? And then I plotted that weight by stage. And you can see that women with stage 3 reached a significantly higher weight than even women with stage 2 and a much higher weight than women with stage 1. So somehow lifestyle and genetics play a role in the growth of lipedema tissue. And I think this should now become a question that we ask our patients. We shouldn't just ask about when did you develop lipedema, what kind of food do you eat? We should say, what's the body mass index of your mother? What's the body mass index of your father? Because lipedema can come through the mother or the father's side. And the reason for this is in a study that analyzed 100,000 children from 6 countries, including the US, 20% of a child's BMI is inherited from their mother and 20% is inherited from their father. So can parental BMI help predict which women with lipedema are at risk for advancing to higher stages? And I think this is important because we should focus on maintaining current weight or even trying to reduce a little bit of the non-lipedema tissue in women who are at very high risk because of their parental BMI. And again, we know that in obesity, high levels of saturated fatty acids contribute to adipose tissue inflammation and dysfunction through TLR4. So it's the same exact mechanism. Why would it not make lipedema fat grow? So now I want to talk about a little bit about leaky vessels and lipedema. So we know that estrogen causes leaky gut through reduction of zonulin 1 mRNA, but it also affects microvessel endothelial cell permeability. permeability. So this is an example of a tight junction between endothelial cells, and it's very complex. There are a lot of proteins involved. And what estrogen does is it redistributes junction forming protein. So they're not in the right place. That weakens that connection. They disconnect adherens junction proteins from the cytoskeleton. So in addition to redistributing them, they're removing their connection to the cytoskeleton. So there's not that inner cytoskeleton connection to that tight junction. And they also redistribute VE cadherin, which is a very important member of the adherens junction complex. So estrogen does very complicated things with this tight junction. And this may be one of the mechanisms, just like a mechanism where estrogen increases leaky gut. This may be a mechanism why estrogen also increases the number of leaky vessels in lipedema. And this is a very nice paper out of Vienna showing that there are leaky vessels in lipedema. And they did this by taking the stromal vascular fraction, which has lots of different cells in it, which are listed there on the top, including endothelial cells. And they reformed these endothelial cells in culture. And then they asked AI, which one of these vessels are leaky and which one of these vessels are not leaky. And you can see the blue is endothelial cells, and the red is that zonulin one in the tight junction. And what the AI did was it identified more vessels as leaky in lipedema tissue compared to the controls. And then they took the stromal vascular fraction, just took that and grew it out. And then they took the fluid that the cells in culture produced, and they put it back onto normal endothelial cells, and they got leakiness. So there's something that's being secreted from lipedema tissue that is causing these vessels to leak. And this could be inflammation it causes the leak, but the reason it does is because of the high estrogen level of the tissue. So that high estrogen level of the tissue sets up these junctions to leak. And we shouldn't forget about lymphatic cells. So lymphatic endothelial cells also react to lipopolysaccharide by leaking because of the induction of pro-inflammatory cytokines. Therefore, I think lymphatic vessels contribute to the leakiness and filling that interstitial matrix with fluid, just like small blood vessels do. So they're working together. So if that's true, we should see increased fluid in the legs of women with lipedema. So we looked at my patients by bioimpedance spectroscopy by stage. And you can see that there's an increase in water in the legs with stage. This is because there's more lipedema tissue. This is because there's more tissue in general. But I think it drives home the point that fluid is important in the pathophysiology of lipedema. We've got leaky blood vessels, we have leaky lymphatic vessels, we've got more fluid in the legs by stage. And this is still a point of controversy. There are still significant researchers, clinicians, and societies that say there is no edema in lipedema. And I think there's a misunderstanding of what edema is. And edema is simply increased fluid in the interstitial space. And I think that's what we have here in lipedema. So a question I have, especially for our nutritionists out there, is would intermittent fasting improve leaky tissue in lipedema? Because we showed that fasting actually is immunologically fit for tissue and decreases microvascular leakage. I had put on that slide that prolonged fasting can cause leaky vessels, but there are other papers that show that prolonged fasting actually helps even ischemic vascular diseases. So I know that we've got a lot of proponents of the ketogenic diet, and that's a form of fasting. And I know a lot of women with lipedema do intermittent fasting to keep their tissue stable or to lose some of the non-lipedema and perhaps even the lipedema tissue. So I think we should think about the underlying mechanisms of why, for example, the ketogenic diet works or why intermittent fasting works and how it improves leakage, maybe even of the gut tissue as well. And there's some papers in the literature that suggest that as well. So I have a huge questionnaire. It's like 65 questions that I give my patients, and they struggle to fill it out, but they do fill it out because they're so interested in getting better. And there's very little data in the literature where women answer these questions. Do you swell? Are your legs heavy? And do you have pain, and where is it? So you can see here, and I know this is busy and I'm going to simplify it for you, but I drew a line at 50%. And my thinking is that if 50% or less of women have a particular symptom or sign, it's probably not as important as if 50% or more of the women have that complaint or that sign. So you can see for swelling, basically on the left here, we're really looking at the calf and the ankle. For heaviness, the upper arms are usually heavy, and that's absolutely true. The abdomen is heavy. And this is also a point of contention, is the abdomen affected in lipedema? And if you attended our research webinar this month, you would have heard Dr. Sinti say that he thinks that lipedema is a systemic disease, and I agree. And you can see here that women with lipedema are complaining of a very heavy abdomen. Why is that happening? Is that lipedema tissue or is it not? You can also see that they think their thighs are very heavy in the front, the sides, and the back. And again, that the calves are very heavy. And then pain, their arms are painful. Their lower arms are not. Their abdomen is not painful. So it's heavy and not painful. These are things we have to think about and figure out. And what I found to be very interesting is the lower back is very painful. And that may be because of the change in shape of the tissue, causing that lower back to be in a more lordotic state, and sway back, where they have sway back. And we don't really think about this. We don't really address this. And I think this is an unmet need in the lipedema population. And then the thighs and calves are also very painful. So let's look at the difference between the calves and the thighs. So the calves are painful, they swell, and they're heavy. The thighs are painful, they're heavy, but they really don't swell. And why is that? And I will propose that the connective tissue of the thigh is different than the connective tissue of the calves. The connective tissue of the thighs actually can accommodate more fluid and can grow more than the calves. And we'll take a little bit closer look at that. So when you stand, your blood moves out of your thorax, down the body, into the abdominal vena cava, and into the leg veins. And this is under pressure exerted by a fluid vertical column. And we think that it's this fluid and the inflammation that accompanies it that is causing lipedema fat to grow. So looking at it again, when you are lying down, your fluid is equilibrated. When you stand, that fluid column drops down, and the highest pressure of fluid in the body when you're standing is in the calf. When you walk, this fluid pressure actually decreases. So there's something that's going on with walking that moves that fluid out of the body. And that's one of the reasons why we tell women with lipedema and lymphedema and venous disease to move, because the calf muscle pump moves that fluid out of the leg. So here is the fascia in the calf. And this is just part of it. But you can see how intense it is. There's a very strong amount of fascia that extends off of the tendon. There's multiple layers of fascia that surround the gastrocnemius, the calf muscle, and extend up into that popliteal space. And when you try and you grab thigh tissue on a woman with lipedema, you can. When you try and grab calf tissue, it's very, very difficult. So I think this compartmentalizing ectoskeleton, which is the connective tissue of the calf, is a part of the pathophysiology of lipedema as well. And I'm wondering, does the calf fascia weaken in lipedema, allowing that swelling to occur? So let's unpack that. So we know that adipose connective tissue is different between women and men. Women have more fat than men. And I think you can see the difference in the adipose connective tissue between the left and the right side here. There's definitely more holes, and that's where the fat is located. And then you can see the spaces in between the holes are very thin in female fat compared to male fat. They're much thicker in male fat. So it looks like female fat is weaker than male fat. So they actually put weights on this tissue and found that male fat is definitely stronger than female fat. So perhaps as females, we are set up for our fascia to become broken, to stretch more than a man's tissue, because inherently it's weaker, and this may be under the influence of estrogen as well. And I and my colleagues have reported previously that about 60% of women with lipedema have hypermobile joints. And it's not just the joints that are hypermobile, it's also the connective tissue. In this chart review of 100 women with lipedema, we looked at their Beighton score, where a score of 5 or more is positive for hypermobile tissue, even if it's non-specific hypermobile tissue or generalized hypermobile joints or hypermobile Ehlers-Danlos. We did not go that far into that in this study, but it does look like about 75% of women with lipedema have hypermobile joint in this latest chart review. And we know that tendons, chondrocytes, and fibroblasts express TLRs, and they can upregulate the NLRP3 inflammasome. So why not fascia? So I think what we're looking at here is, number one, we've got increased fluid pressure in the calves. When just everybody has it when they stand. And in women, we have weaker connective tissue. So that connective tissue might start to expand or even break down a little bit from that pressure. Now you add on hypermobile joints or hypermobile connective tissue. So there's something different about the connective tissue. And often this is a loss of elasticity. So the tissue stretches even more. And you can think about it, if it's stretching, if it's breaking down, if there's inflammation, there's likely the growth of fat tissue. So this excess interstitial fluid may induce fat growth and lipedema, as in lymphedema. And this lymph fluid is directly derived from the interstitial fluid, which bathes those cellular layers. So this interstitial fluid may make the fat grow. So we looked at our women with lipedema, and my hypothesis was that if this is true, that this fluid column increases interstitial fluid along with the leaky capillaries and the leaky lymphatics, that we should see an increased growth of calf fat before we see an increased growth of fat that covers the knees and moves on up. And I actually have half stages here, and I've been experimenting with different staging of lipedema because I don't think that our stages of lipedema adequately describe what we're seeing. That's a whole nother talk. But you can see that early on, even in stage 1 lipedema, that a lot of women, over 60%, have fat that completely covers their shin bone. And this is a very easy physical exam that you can do if you're trying to diagnose lipedema, is just to run your hand on that anterior shin, and you can just feel that you cannot feel the bone. There is a layer of fat there. And I think that as women age, because our connective tissue is weaker, because our veins become weaker and perhaps leak more or reflux more, we're going to grow more fat on our calves over time. So women in their 60s, 70s, and 80s, you might start to be able to feel some fat covering that shin bone. But that weakness, that increase in fluid is happening a lot sooner in lipedema. And you can see on the left side that in stage 1, there are very few women who have fat that completely covers the knee. Usually I can feel a little quarter size area on the knee that is not covered. So I say, oh, you know, your knee is not completely covered by fat. But you can see as women progress in stage, that fat is more likely to cover the knee, and it reaches almost 100% in stage 3. So I do think that fluid dynamics in the body affect the growth of fat and lipedema. I do think that inflammation definitely plays a role, and it's exacerbated by other inflammatory conditions such as obesity, and that leaky lymphatics and leaky blood vessels contribute to this fat growth on the legs. I also think vein disease is prominent in lipedema, and I'm hoping we have some vascular phlebology folks in the audience because we really need good studies of the veins in lipedema. And just using thermography, I can identify visible varicose veins in lipedema. And you can see a thermography photo over to the right, and this is the back of a woman's calves, and you can see the lightning bolt dilated veins in the leg. And this would be a positive identification of varicose veins in the leg. You can also identify spider veins just by physical exam. So we have increased spider veins, increased visible varicose veins, but very little corona phlebectatica. And corona phlebectatica is that spider pattern that you see on the inner foot near the medial malleolus. And that signifies chronic venous disease. So it seems like the vein disease is a little bit different in lipedema than, I would say, regular venous disease or non-lipedema venous disease. And we need to figure that out. And what we've seen by ultrasound is that there are a lot of dilated peripheral veins or veins that are close to the surface of the skin. And that suggests that there's some increased pressure in the veins deep that is feeding back to those veins all the way up to the skin. But we don't have a lot of data on small vein disease. But it's very clear if you read through the literature that there's perivascular inflammation around veins. And you can find paper after paper on this. So how does this perivascular inflammation contribute to lipedema? Well, probably through TLR4 receptors and the inflammasome. So varicose veins may be another means for fat to grow in lipedema in addition to genetics and lifestyle. So I really hope that someone actually takes this on, because, you know, my question is, does swelling, heaviness, and pain in lipedema tissue result from venous disease and lipedema, in addition to all the other pathophysiologic mechanisms that we talked about today? And look at the extent of these veins. And in a webinar that Dr. Jose Luis Simaro and I gave on compartment syndrome, we showed that the small saphenous vein that's on the back of the leg wraps around the lateral malleolus. And if you have increased pressure in this vein, it pushes fluid down around that lateral malleolus. Well, fluid makes fat grow. Is that malleolar fat pad that we see on the outside of the foot due to venous disease and lipedema? That's something that we need to verify and find out. And that makes lipedema very complex, right? We don't have a gene for lipedema. It's been very difficult to find. And I think the reason is because so many different things contribute to it. And if we can identify those, we can prevent. So in summary, lipedema fat may grow secondary to immunologic fitness. It's not just pregnancy that can cause a subclinical inflammation in tissue in that gluteal femoral white adipose tissue, but it could be this increase in aromatase in the lipedema tissue, which increases estrogen, decreases that zonulin 1, resulting in a leaky gut and subclinical endotoxemia. This inflammatory response is regulated by decreasing pyroptosis of adipocytes. And you saw how complex that regulation was. But I think we still can ask, is lipedema fat in a state similar to pregnancy? And I think inherited obesity and other inflammatory diseases may bring immunological unfit adipose tissue into the same location as lipedema, and it may stay. So should women with lipedema fast? And I'd love to hear from the nutritionists in the audience. And I think this should be one of our focuses. What I'm saying is, I don't think that lipedema is just obesity. I think obesity complicates lipedema, and other inflammatory states can also complicate lipedema, like autoimmune diseases and allergies and mast cell activation disease. And I think fluid dynamics really impact the body location of swelling. That swelling increases the risk of regular inflammation. And again, regular inflammation can make lipedema fat grow. And this inflammation causes the vessels to leak fluid into that interstitial space. Gravity forces fluid into the legs, especially the calves. And strong fascia is really important to force fluid back out of the calves. And this means that compression garments are very important in lipedema, especially of the calf. Exercise is very important in lipedema, especially moving that calf muscle, causing it to contract and help that fluid to get out, and keeping the fascia drier and not surrounded by a lot of fluid, which would cause it to break down more. And I think we need to ask the question, does weak fascia influence swelling in the calf in women with lipedema? And this weak fascia may result secondary to some mutation in connective tissue that we don't know and that we have to figure out. And they don't have the gene for hypermobile Ehlers-Danlos syndrome because, again, it's probably very complex. And there may be inflammatory factors which are causing this weakness, and it's not necessarily a mutation in collagen or a mutation in the extracellular matrix, but a complex set of inflammatory reactions that are causing this weakness in the fascia. You combine that with just the fact that women have weak fascia compared to men, and you get swelling. And does vein disease influence swelling in the calf in women with lipedema? This is a big elephant in the room. It screams for more research in this area. And I think that we should have a campaign to make that happen. So thank you so much.
Thank you, Dr. Herbst. You have not only presented amazing information, but provoked so many questions from the audience. And people don't want to hear from me. They want to hear from you. So if you don't mind, now I know you're getting on a plane and going to Australia. How much do we have? At least 15 or so.
Absolutely. Let's do this.
We're going for everybody. Buckle up. Here we go. We're going to get through the questions, as many as we possibly can. Dr. Herbst, Connie Coltrane, thanks for being out there. Is there a relationship between lipedema and small fiber neuropathy?
Absolutely. I think that's also an unmet need in lipedema. And we have data that we really need to publish showing that as you increase in stage, your veno, arterial, or reflex stops working. That means we're letting more fluid into the tissue. The nerves are sitting within that tissue and becoming inflamed. So absolutely, yes. And more research needed in that area. Calling it out.
Yeah, more research needed across the board. Thank you for continuing to ask the questions, though, Dr. Herbst. It's amazing. Lisa Silvestri, one of our clinicians out there, we're so glad you're with us, Lisa. When patients come to CLTs with suspected lipedema, who do we refer to for the appropriate testing? For instance, macrophages, etc.
That really is still research-based. So we need more clinicians that can diagnose and treat women with lipedema. And I really think that CLT should be able to diagnose lipedema. That's just my opinion, because you know the tissue better than most doctors, most nurse practitioners. And so I applaud you for all of your knowledge. And if I were on the board, I would let you do it. Um, but I hope, as part of the Roxbury Institute, to develop an educational program to educate nurse practitioners and MDs to be able to diagnose, to give you more people to refer to. But you are such a great collaborator, and thank you for all you do.
We so appreciate the relationship that we have with certified lymphedema therapists. In fact, one of the questions that came through from the audience is, how do I get connected to get a diagnosis? How do we identify a doctor who's well-versed and who believes in lipedema? That's from an anonymous attendee.
So the Lipedema Foundation has a list of providers, and I think that would be my first go-to list.
Yeah, and that's lipedema.org. And I also want to suggest LymphaPress is connected with some of the best therapists and people that can diagnose this condition around the country. So just go to lymphapress.com. There's a contact us button. We'll be glad to connect you with your local rep. We know, and you're aligned with LymphaPress, Dr. Herbst, because you know that the pneumatic compression therapy can truly help. We had one person ask about pain, and we've seen patients have reduced pain, increased mobility, and even reduction. Could you speak to the efficacy of the LymphaPress pneumatic compression pump before I get into the other questions?
Sure. And I also want to say that LymphaPress isn't just present in the US, it's present in Europe too. And so you can find, if you need to find a provider, you can contact LymphaPress. They're all over Europe. We just finished a study on women with lipedema, and we looked at a number of different items before and after using the LymphaPress pump, especially the LymphaPants. And just like a sneak peek, the data is so exciting. We showed that there was a decrease in pain, and there was an increase in the ability, or the want or ability, to socialize. So after using the pump, women were more likely to be social than if they didn't use the pump, which I find to be fantastic. So their quality of life improved significantly after the pump. We also looked at their fat tissue, and we were able to show a decrease in their fat tissue. And we're still working on the volume. So far we have a reduction in volume in the left leg, and we're looking at it a little bit differently, but I'm hoping that we get that publication out soon.
Oh, we're waiting with bated breath. That's awesome news. And for lipedema patients out there, we know we have patients and clinicians in the audience. There is a whole repository of video testimonies on the Lipedema channel on YouTube, which is hosted by LymphaPress. You can be inspired by other patient stories. Francine Schwartz, who is one of those interviews that we did, asks, is there a relationship between lipedema and irritable bowel syndrome?
Well, that's super interesting. So if there's leaky gut due to high estrogen levels from high aromatase and lipedema tissue, that in and of itself may be at least an exacerbator of irritable bowel. There's also likely an association of lipedema with mast cell activation disease, and mast cells line your gut. So if your mast cells are just a little bit excitable every time you eat, they could get excited, secrete cytokines, causing swelling and irritation of the gut. I think it's pretty complex. It's not very simple, but I also think that women with lipedema have a lot more allergies. And if you have irritable bowel, I would suggest going to an allergist and at least get tested for food allergies to make sure you're not eating something that you think is healthy, but is actually irritating your gut.
Thank you. That's excellent information. This question came in from Linda Verbance. Linda, we're so glad you're with us for the live. She wants to know, have you discovered any correlation between having taken birth control pills back in the 70s and 80s and lipedema?
Well, if you think about it, if estrogen weakens not only the gut, but endothelial cells and blood vessels and lymphatics, perhaps the birth control pill might do something similar. And I get this question all the time, and we have no data on it. So this is very anecdotal. We really need a research study on it. But what I tell patients is that if you do go on the birth control pill, as low of a dose as possible, and to go on one that has stable levels of estrogen instead of spiking estrogen just like you would in a menstrual cycle. Go on one that's got the same amount every day and as low as you can.
Mm. We've had a couple of questions come in regarding your comments about fat content and saturated fatty acid, and trying to connect the dots between the keto diet, which is high in saturated fatty acid. Do you have any comments on that? And by the way, we are not either diagnosing or prescribing any course of action for anyone today, but anecdotally, do you have any information between the fat question, ingesting fat, and the keto diet, which many people purport to be beneficial for lipedema?
Yeah, I would say that there are all sorts of different keto diets, and they don't all have to involve saturated fat. And I think that kind of a trend is to go towards a more healthier keto diet rather than eating just, bacon and dairy products. And, I think women with lipedema are super savvy, and they do eat nutritiously, even if they are on the keto diet. And a lot of them are seeking out nutritionists to help them eat as healthy as possible, but yet stay in ketosis. And we know that ketosis actually can improve can be anti-aging for our vasculature. So I think that it's very complex, that yes, you could be eating saturated fats, but still be in an anti-inflammatory state, because you saw how complex inflammation is. So you're going to have one part affected maybe by saturated fats, but maybe 10 or 20 other parts that are working against it.
Mm.
More research.
More research. Colin Dean asks, could the presence of edema in lipedema patients correlate to another cause like obesity or chronic venous insufficiency?
Absolutely. That's exactly what I think. And we know there's something called obesity-related lymphedema. And what does that involve? Inflammation and leaky vessels. And so we're still on the same spectrum with lipedema here. And I also think that, again, venous disease, especially venous insufficiency, that we don't really understand completely. We need more work on the compartment syndrome and what role that plays. But again, I think the pathophysiology of lipedema is very complex, and what we're trying to do today is unpack it in little parts, and vein disease, I think, does play a role.
We also know that you're an expert when it comes to DIRCMs, and we have a question from an anonymous attendee asking, if you have DIRCMs, do you have or will you inevitably develop lipedema?
That's a great question. And my undergraduate student, who's now a physician, Karen Beltran, and I looked back at all of my patients and said, how many have lipedema? How many have DIRCM's disease? How many have both? And it was a small percent that had both, but it makes perfect sense. If you're a female, you have inflammation, you have leaky gut, you're going to grow some lipedema tissue along with your DIRCM's disease. And I have a patient I just saw, she's got DIRCM's disease, and now she's growing what looks like lipedema tissue, but it's super, super fibrotic. I think they both involve inflammation, and DIRCM's disease, I think, has higher levels of the more pathologic, unfit inflammation than lipedema fat, but it's contributing to the growth of the lipedema fat, just like metabolic obesity would.
So you mentioned hypermobility.
Mm-hmm.
How does someone get tested and diagnosed for hypermobility?
You can see a rheumatologist or a geneticist. Those two specialties often diagnose hypermobility.
Okay. Any extensive research on leaky gut syndrome? This attendee says they've known of a holistic doctor curing leaky gut with diet.
Yes, that's often the case. And there's a lot of literature on leaky gut. When I first was at University of California, San Diego, I mentioned leaky gut and I was told that's not a thing. And now you look in the literature and it's everywhere. So yeah, there's a lot of information on leaky gut, and diet is very important. And again, we were talking about saturated fats. It's not just saturated fats. There's a lot more, more going on because our immune system surrounds our gut. So inflammation and different mediators of that inflammatory process are playing a role. But I think an anti-inflammatory diet plays a huge role in.
Play whack-a-mole with the questions. We've got more that keeps springing up. We love your questions, and we are so glad that you devoted time to be on the live today. Everybody's going to get a copy of the recording. You're going to get a link to it, because unpacking a lot of this information takes more than just one listen. We had a really interesting question here, and I love it, actually. What was the catalyst for you to research lipedema?
Oh my goodness, that's a long story, but I've had an interest in fat ever since I was a kid.
I know
And
you have. You've been curious about fat, and I would direct the questioner to the LymphaPress website. We did a leadership series and we interviewed Dr. Herbst and we heard her whole backstory. So go to the leadership series on the LymphaPress website and you'll hear all the details. I was fascinated by that too. And I think a lot of people ask that question simply because they're just so grateful that you chose to follow this path and follow your curiosity. So back to the questions. Do MRTs affect lipedema like birth control?
MRTs,
I know, I was wondering what MRTs are as well.
MRTs, I don't
If
know.
if you could put in chat what you mean by MRTs, because if Dr. Herbst is stumped, maybe we're getting it wrong. So some people have pain, some people do not, even though they have lipedema.
Mhm.
Natalie Mayhood, I'm hoping I'm pronouncing your last name correct, Natalie. She says she's stage 3 and doesn't have a lot of pain. And we're grateful for that. But why
Yes.
is that?
We don't exactly know, and there's again, that's very contentious. There are people that say if you don't have pain, then you just have lipohypertrophy, even if you look exactly like lipedema. But my feeling is if a woman with lipedema goes in for treatment and she gets her pain reduced to almost nothing, does she no longer have lipedema? So we need to resolve that issue. I believe that many women with lipedema have pain, but there are some women that don't have pain. And if we could study the difference between the two, that would probably give us some answers.
And the word pain means different things to different people too. When I was interviewing some lipedema patients, their pain was more of an ache that exists in their body and in their limbs. So yeah, and we do know that the LymphaPresses help people. If you have your hand raised, please put your question in the Q&A and we will get to as many as possible. Marguerite Andrews is curious about the connection of a high ratio of omega-6 to omega-3, as high levels of omega-6 are inflammatory. Have high levels of consumption of omega-6 been shown to make lipedema worse? Or is that needed to
No,
be studied as well?
there are no studies on that, but I totally agree with you that it's important to change your fat cell membranes so that they're as healthy as possible and get omega-3 fatty acids into those membranes. And if you want to figure out if you have high omega-6 fatty acids versus omega-3, you can run an essential fatty acid profile in the fasted state. And then you could take your arachidonic acid to your EPA ratio, and really what you want is a 1-to-1 ratio. If it's different from that, then you need to increase your omega-3s.
You will definitely get a transcript of this recording so you can write that down, because that was a lot. I wouldn't even know how to spell some of that. But Laura Chastain wants to know why our body creates a lipedema cell, then also a lipoma as well, right along with the lipedema cell.
That's a really great question. And I think it has to do with the fibrosis in the tissue, the fat lobules. And what's interesting is that if you do a biopsy of fat, you're going to find a lot of blood vessels, but you're going to find very few lymphatics. So in order for that fluid to get out of the tissue, it has to traverse that interstitial space for quite some time before it is taken up by a lymphatic vessel. So all that fluid sitting around would make it grow. it would generate inflammation, and the connective tissue that's surrounding that lobule would become thickened and firm or fibrotic. And we've actually shown that in our standard of care paper. And there's your lipoma right there.
Leaky blood vessels. Would you see evidence of those in your skin?
Oh, yes, absolutely. In fact, my group and I did biopsies, and we looked at the vessels in the skin, and we proved that there were leaky vessels. And in fact, if you were on the research roundtable, Dr. Sinti also showed by electron microscopy that there are leaky vessels. So it's absolutely true.
So we've got clarification on the letters we didn't understand. She actually meant HRT, hormone replacement therapy. So we have a couple questions here. Do hormone replacement therapies affect lipedema the way birth control does?
Again, it's no research, none. So what I recommend is that you take hormone replacement therapy in the lowest level possible. And actually, there's good data showing that it's very beneficial to women, but you should start at the time of perimenopause or menopause and not wait, 20 years down the line when you've already developed cardiovascular disease and then start it.
I know that there's so many women, especially in the lipedema patient community, who are advocates for getting information into doctors' offices early on, so that when young girls who are entering puberty and seeing some of these signs, they can sort of start getting treatment so that it doesn't go. So many of the patients I've interviewed, they were 50, even 60 years old, and they finally got a diagnosis after dealing with this for years. How does lipedema cause tachycardia?
Lipedema can be associated with autonomic dysfunction, but there's not a lot of data on lipedema and tachycardia. There is some data showing that the aorta is dilated in women who have lipedema, that the twist of the heart is different, and that aorta can become fibrotic. And with that, I'm going to be on KTLA, so I have to run.
We just discovered a lightning in the bottle, which would be Ask Dr. Herbst, a brand new show. Something we might want to consider. Thank you, everyone, for your questions. Please go to the link tree for LymphaPress to connect with all of our content opportunities and the ways we support patients and clinicians. You are sprung, Dr. Herbst, but we thank you and we appreciate all you do for lipedema, not just during Lipedema Awareness Month, but like LymphaPress all year long. Have a great day.
Thank you, everybody.
See ya.
Bye-bye.